Hey, everybody. For anybody who's watching, thank you so much for joining our panel today. We will be starting in 1 minute. Okay, so hi, everybody. Welcome to our panel. We are the Center for Civic Justice. We are a department on campus that's dedicated to helping students vote, as well as helping them become more civically engaged in their campus communities. My name is Pooja Madanraj. I'm an undergraduate coordinator.
Hi, everyone. My name is Marlene Rahman. I'm also an undergraduate coordinator. Thank you all for watching.
Hi, everyone. My name is Jolie Vidal, and I am a student intern here.
Today, we are here with SB Home, two medical students from SB Home, and we're going to be talking about medical access within the immigrant population. So if Rachel and Kate could please introduce themselves.
Okay, sure. I'm Rachel. I'm a third-year medical student. I'm the current co-chair of the steering committee for our free clinic at SB Home. It's nice to meet you all.
Hi, everyone. My name is Kate. I'm currently a fourth-year medical student. I'm a student volunteer at the Free Health Clinic.
Yes, so thank you so much for introducing yourselves. So what is SB Home for those that may not know?
Sure. So Stony Brook Home stands for Stony Brook Health Outreach and Medical Education. We're the free clinic that's associated with the Stony Brook or the Renaissance School of Medicine at Stony Brook. And we take care of the Long Island uninsured population. So we give free medical care and primarily primary care to our patients who are uninsured. And we provide things like outside of doctor's visits, we do social work insight, we do in-house laboratory services. We have dietetic interns that help our patients with the nutrition, and we connect them with lots of different resources in the community that are associated with their health and things like that.
Wow, that's amazing that you guys are able to do that for people and that it's free, that these services are free. So I'm going to go ahead and ask you the first question that we have for you today. How did you get involved and passionate with serving the home clinic?
I can go first. So I first heard about the clinic during my medical school orientation. There was info session, and hearing about just what the clinic does was very inspiring, and there were a lot of opportunities for first and second year medical students to help with the clinic, mostly behind the scenes, like scheduling committee. Accepting, returning patient phone calls, and then schedule appointments for them during when we are not in clinic session, as well as helping out with the lab review. Like we literally organize the lab results that we get faxed from the laboratories, and then organize them in a way that higher, like senior medical students can review for the next clinic day. So that was my first exposure as a first year medical student, and later on, as I graduate, like into a clinical student role, I was able to see patients in the clinic. And I think the work is very rewarding. I am going to family medicine. I always knew I wanted to do primary care. So the clinic was a great place for me to not only get more exposure of the field, but also connect with a lot of senior students, like my mentors, and also attending physicians who are in the primary care setting.
I think that similar to Kate, my experiences with the clinic started out relatively early. When I was actually interviewing at different medical schools and looking at schools to apply, one of the criteria or one of the things that I looked at when I was applying was whether or not the schools had a free clinic. And something that really stood out about Stony Brook is that our free clinic is essentially a fully functioning primary care clinic. A lot of other free clinics that are medical student clinics, they aren't really able to provide primary care in a general sense of the term because they don't really have the capacity to do continuity of care, which is really important in a primary care setting. And at Stony Brook, we are able to do that. So that was something that had really impressed me. And when I started as a first year, I got involved with the steering committee because what I want to do after medical school involves things like health equity and social determinants of health. So that's primarily why I was drawn to the clinic in the first place.
Okay, thank you so much for that detailed response. Rachel, just in reference to you, like, what do you want to do after medical school then?
Sure. So I'm not as far as Kate is. Kate's going to graduate soon and she's already matched. So congratulations to Kate. But I'll be applying to pediatric residencies. And I want to work in health equity and underserved populations. So I'm looking to be in a more urban environment and potentially continue the research that I currently do now, which is social determinants of health research. So that's where my interests primarily lie.
Okay, amazing. I'm going to pass on now to Marlene, who's going to ask you the next question.
Thank you so much to you both for sharing. So our next question is, what are some ways civic engagement has been intertwined in your journey to medical school and as a medical student?
I can. Oh, sorry. I'll go real quick.
Yeah.
So actually, interestingly, prior to medical school, I have very little exposure to any sort of civic engagement. I grew up in China. I came here, for college at the age of 18, and the political structure was very different there, and I had very little. Even exposure or encouragement to participate, like in an active way, as a citizen. So I always kind of label myself as someone like politics and advocacy is just not my thing. And I didn't really gain a lot of exposure prior to medical school. However, ever since medical school, serendipitously, I was able to gain a lot of exposure in how advocacy works, as a medical profession. I got involved. I went to a family medicine conference, as a first year student, and I saw examples of family doctors how they use organized medicine, with the American Academy of Family Physician. They will pass resolutions in their Congress of Delegates, and they will actually have recommendations and actions on the National Congress. Those are real life examples how someone's idea for social justice, and your activism really translates from simply an opinion to action. So I think that was very inspiring for me. So I started to be trying to gain access to more of these events. I participated in the New York State level Family Medicine Academy at their Congress of Delegates, and really was reading the resolutions last year, providing testimonies. And actually, like my testimony actually, I felt that it was being heard by the reference committee, and it was eventually voted on, and it was passed. It was about ending discrimination for transgender athletes. Is something I was very passionate about. So that's just a very little example how I think as medical students we're fortunate to be able to have so many opportunities to actually be engaged in our society outside of school.
I think my experience was a little bit different. So I grew up in the Bay Area, and I went to college in the Bay Area as well. So I was very, very heavily involved in my community, and community health was something that really mattered to me, because I identified a lot with the people in my community, and with the people that I had grown up with, and the people who had basically raised me. So during college, I did case management at a county clinic, and we basically did social work for patients who were undocumented, who were immigrants, who were underserved, who were uninsured. And that was a huge privilege, and kind of offered a new perspective on how, public health and public policy are all sort of intertwined. And like Kate said, coming to medical school and being a medical student and eventually becoming a physician, and really honestly in any medical profession, public health is so heavily involved in the lives of everybody, really. And public policy is also, as a consequence, really intertwined in that as well. So it's very hard to go through medicine in any sort of career and not have to kind of reckon with a lot of the inequities that we see within our communities. And I think that most of us as medical professionals, have a sense of responsibility or obligation to really address a lot of the inequities that we see, because those inequities have a huge impact on our patients' health, and have a huge impact on how we practice in general.
Thank you so much, Rachel and Kate, for sharing. I think it's really important that you brought up just how intertwined civic engagement is with medicine and advocacy and activism, and just how intertwined those concepts are. Because a lot of the times in STEM-focused students, civic engagement often can get brushed under the rug or neglected. So it's really important that future medical students and future medical professionals just understand just how important advocacy is, especially for your patients and for legislations. So I'm going to pass the mic over to Jolie for our next question.
Yeah, thank you so much for telling us about how that intertwined into your journey going into medicine. But I think now we want to just know, how do you feel your time at the home clinic has made you a more aware and more civically engaged medical professional?
I think something that's really wonderful about our free clinic is that we have social work on site, and that we have like nutritionists and a lot of different services. And part of working at the SB Home Clinic, whether it's as a clinical student, as a preclinical student, as a medical translator, we all are aware of the social issues that are affecting our patients. And the way that we practice medicine within the SB Home Clinic is very different than the way one would practice medicine at, say, a private practice. And that's because our patients don't have access to the same resources that other patients might have access to, whether that be for financial reasons, whether that be because they're undocumented. And when you volunteer at the clinic, you have to really keep those things in mind whenever you do anything, whether it's prescribing, whether it's referring patients out to different services. When the patients come through the door, when we do intake, we have to take into account, can the person read and write? Is English their primary language? Do we need a translator? Do we need our forms in Spanish as well? So all of these things, are really emphasized. And like Kate had mentioned, within family medicine really takes into account a lot of, the social determinants of health for a patient. And that's really what our clinic is. It's a family medicine clinic.
Yeah, so wonderfully put, Rachel. So I'm just going to add on a few things. I think my involvement with the clinic in the past year and a half has mostly, as a clinical student, I was able to see patients independently. And, now that having some clinical rotations, in our university affiliated clinic under my belt, now when I'm seeing patients in SB Home, I really you can really feel the difference, like we are our patients, like most of them have very poor access to healthcare, and just being able to listen to them and taking care of them, understanding what are some barriers to their health, sometimes it's things that we are not taught in med school. It's not necessarily considered medically relevant. In the it's things like food insecurities, housing insecurities. People have no access to transportations. These are all things that can increase the cost for them to achieve the same kind of health outcome as just other people who are documented and have health insurance. So like being able to taking care of those patients, like listen to their stories, really trying to make sure that they understand our instructions. It's the nitty gritty little things that we need to figure out so that they can actually get their medications at a reasonable rate. And those are little things I think that experiences every single time at every time at the clinic. Those experiences really reinforce, make me more aware of like, these are the things that are usually hidden in our medical system, and makes me, just fuels me to keep going, to be more civically engaged and really work on what I can do, as a physician in the future to work on these social determinants of health, and how can I, to make sure more people can achieve a health equity.
Thank you so much for that response. And it's really interesting just hearing about you guys' experience, learning about all these different factors about social determinants and looking at the different patients that you have. And it just seems like SBU Home Clinic is a really good thing that at least Stony Brook Medicine has to offer and giving you guys more of that exposure. So thank you. I'm going to hand it back over to Pooja for the next question.
All right. Thank you so much, Jolie. Our next question to you guys is, are there any like policies or pieces of legislation that you feel has hindered your ability to treat certain populations of patients, or any policies that you see prevent patients from getting the full treatment that they might need?
Well, I think in general, like Kate and I have both spoken a little bit about how public health and public policy are really interconnected. As medical professionals, we rely on an infrastructure in order to take care of our patients. So in terms of the medical care that we're able to give, a lot of our patients are undocumented. Most of them, or all of them, are uninsured. Most of them are from marginalized communities. We're able to give them the same medical care on paper, I suppose, but we're limited by things like finances. So obviously, if everybody was insured, if undocumented immigrants had access to things like Medicaid, to services like Medicaid, Medicare, even things like SNAP, we wouldn't have the same issues that we do paying for things. The clinic would not exist if everybody was insured. And we wouldn't need to exist. But because there is such a large uninsured population, we have to kind of fill a role. And we're happy to do that. But what limits us really is the ability to finance a lot of the things that we do. So our clinic pays for all of our patients' lab work. We pay for the radiology when we can. We have to give financial help for patients to get radiology. But for things like referrals, if a patient needs more specialized care, we can try to connect them with financial help resources. And our social work intern works very closely with a lot of our patients for that. But because we don't have the financial capacity to pay for everybody's outside medical expenses, we're not able to offer specialized care for our patients in a way that, a normal primary care facility would normally just refer outwards and kind of assume that their patient would be taken care of.
Yes. So from just to give a more like specific example. For example, I had a patient who I actually seen, like twice, 3 months apart. It was completely unplanned. It just happened. It was wonderful to have a little bit of continuity. But like Rachel mentioned, we have social work interns who work very closely with our patients to get financial assistance. So more specifically, we are getting financial assistance through the Stony Brook medicine system. However, so basically Stony Brook, they have this approval system for patients who are uninsured, and based on patient's income, they can give a certain income-based compensation for the patient's healthcare. So some patient can get qualified for up to 95% of the healthcare, covered by Stony Brook. But however, this process is, sometimes it can take months, especially if the patient doesn't have a imminently dangerous medical condition. So for my patient, she has been applying for that for 3 months, and it has not been approved for her. She was here, we saw her for abdominal pain. We've tried the most common, like outpatient therapies for her, but it's just waiting to get that assistance so she can go see a gastroenterologist. Like it's something simple as that, and she's having abdominal pain daily. And it is very, very, it impacts her life. She was not able to work as a result of that complaint. So we can only, we have to try different things, but it will take a longer time because we cannot do more invasive or more advanced diagnostic exams or imaging studies that the GI doctors can do. So that's just an example how the reimbursement, like payment model, like in the society, it's the lack of legislation allowing undocumented or a lot of patients who are unable to get health insurance to gain access to the medical system that we see that really has an impact on their healthcare outcome. And I think maybe I think I remember reading about some places are starting to offer might start to offer Medicaid or Medicare expansion to undocumented migrants, which I think could make a big difference so that they can have more immediate access to different other components of the healthcare system. But just on patients we see in our clinic, like it's really just the not being able to provide the full healthcare system for them has a direct impact on their healthcare outcome.
Yeah, thank you for going into those specific issues. And Kate, especially thank you for bringing up that one patient, because that probably happens to a lot of people. That's just not a one-time story. And I just wanted to go more into like what both of you guys had said about immigrants not being able to access some federal benefits such as Medicare and Medicaid. And the reason why is because of a specific piece of legislation that was passed in 1996 called the Personal Responsibility and Work Opportunity Act. And this is what prevents unauthorized immigrants, and actually most authorized immigrants with less than 5 years of U.S. residency, from receiving federally funded benefits, such as the things that we had mentioned before, Medicare, Medicaid, and CHIP, Child Health Insurance. All right, I'm going to pass to Jolie for our next question now.
So here at the Center for Civic Justice, we've been doing some research in terms of this topic. We had actually learned about some of the hesitations that some of these patients may have. So these can include the fear of deportation, discrimination based on stigma, ability to pay. Have you seen these or any other hesitations in your care of work, and how were you able to address them?
I think that all of these things come up in our practice at SB Home. In terms of the fear of deportation, that's not as common of a complaint or a concern that we get from our patients, primarily because we don't ask our patients what their citizenship status is. We don't keep any records. We don't screen anybody. We don't ask anybody what their documentation status is. So, we've been in the community for quite a while now. We were founded in 2008. So I think most of our patients who have been with us for a long time or have heard about us from other members of the community know that we don't collect any sort of information like that. And quite honestly, it does not really affect how we treat our patients other than what services we might refer them to. In terms of ability to pay, that's a huge theme for us because, like I said, we do our best to pay for a lot of the services that we offer. However, there are always things that we can't pay for. For example, we can't pay for all of our patients' prescriptions. We can't pay for their radiology services. We can't pay for their referrals. And that's always a really big concern, which is why we have a social needs screener. So we screen all of our patients who come through our doors for social needs, such as help paying for medication, help paying for prescription eyewear, help paying for food, transportation, employment, all of those things our patients get screened for. And we have various resources that we can connect our patients for each of those concerns that they might have. So for example, for paying for medication, one thing that we do that all of our attendings know to do and our clinical students know is that when we prescribe medication, we make sure that we prescribe generic brands, if possible, generic forms of the medication, because they're much less expensive. And we also try to prescribe the more affordable formulations of drugs. And then we also, on top of that, have different services that we can use, like GoodRx, that will help our patients afford medications. So there are a lot of different ways that we address all these types of things. But I'll let Kate maybe talk a little bit more about her experiences as a clinical student using them.
Yeah, 100%. GoodRx, I use with every single one of my patients. And Walmart has a $4 drug list, which literally like a month's supply will cost only $4. So we try to prescribe based off of that list as well. So yes, costs might be the most common concern that bring up by patients. And sometimes, like when patients ask, when we're recommending a test and patient would always concerned about like, am I going to be able to afford it? How much is this going to be? So some of the attendings are very good at trying to only recommend, they keep this in their mind when they're recommending tests. Like, like for example, MRI is a very, very expensive study, even though it can tell you a lot of information. But sometimes we learn to weigh the pros and cons of a more advanced, expensive test versus something that is more affordable and patient will more likely to go get. Because at the end of the day, if we give them prescription and tell them to do some test, if they're worried about the cost, they're never going to do it, and that in the long run will hinder their treatment plan. So when we're communicating or giving patients any sort of referrals for additional studies or specialists, we always I always try to do a sit down with the patient and really spend time to explain like why this extra dollars needs to be spent in the long run, just in the perspective of helping them get their conditions under control. And another thing is, I think, like Rachel said, like I think most patients we see in the clinic, they heard about us from the word of mouth, and we do not like ID patients. We don't ask them to provide some form of identification. Most patients are already comfortable, to see us. They're not. I don't think most of them are worried about getting deported. I think if they're worried, sometimes might stop them, from even making an appointment with us. So I think I remember when I was a first year student, when we were getting trained to do patient phone calls, we always tell patient that, we do not require any form of identification, for you, like, so if that's a concern, like, you don't have to worry about that. But I do see that, like, other hesitation at the clinic is just, I think sometimes the hesitation builds up, like they don't want to see a medical professional for as long as possible, but they just pull, their condition is not getting any better and they have anxiety from worrying about their medical condition, and this kind of a vicious cycle, right? The more they more worried about something's going to get more severe, and if some conditions more severe, they think it will cost more money, but they're worried about the cost and they don't want to go to the doctor. So it's kind of like, you see how this is kind of a perfect storm for a very severe heightened anxiety in patients that we see. So eventually when they make it to the clinic, they probably bring up with a handful of like 5 different conditions that they're worried about. That is very, very challenging, for clinical students to manage, because we only have a limited amount of time. But at the same time, all I can do, really is to try our best to address as many problems as possible, and try to a lot of counseling and patient education to make sure that they can follow up with our clinic in the long run, so we can address the most important few concerns first, and then the rest of the issues in the long term. So yeah.
Yeah, thank you so much for sharing. That's really interesting and like just a perspective of understanding how this can be a cycle and how this can, be so repetitive. But the training that you guys get seems like you guys are really understanding to understand the patient, understanding where they come from, but also having them to not fear about getting the help because I think that's the overall goal is to try to get them the help. So thank you so much for answering. I'm going to be passing over the next question over to Marlene.
So our next question is, what changes do you think are necessary to improve access to care in this population?
Well, I think we've talked a lot about how public policy is actually really, really important when it comes to public health and when it comes to our patient population in particular. So I think that a lot of the changes that have to happen have to do with the ability of patients to afford healthcare. When we talk about health equity, the two things that we talk about primarily are access to healthcare, and then whether or not the healthcare that patients are accessing is of the same quality. So it's access and quality of care. And in this case, I think the issue with access to care is primarily financial. So the way that our system is, it can be very difficult to afford for insurance, for health insurance. And a lot of people are put into positions where they have to choose between paying for health insurance or paying for health expenses, or paying for other basic necessities like housing and food. So I think that's primarily where the change has to happen.
Yeah, so just to add on to that, I think 100% like the financial concern is the most the big thing that that makes it hard for these population to get access to healthcare. And at a higher level, really, is the reimbursement model needs to change. If clinics and medical professionals are getting reimbursed for seeing patients without insurance, or these already patients lacking access to healthcare, if other doctors can get paid from the federal government or some other source of organizations, then they will be able to see these patients, right? Because right now we're struggling to find money to pay for these patients to be seen as specialists, or even just other clinic. Our clinic only sees adults, right? Like, and then they might have children who needs access, but due to many factors, we're not able to see children in our clinic. So where are they going to get their healthcare? So if in the larger, like national higher level, I think reimbursement has to change so that we can actually deal with the problem that like the access, and more doctors will open their doors to these patients, and these patients will actually be able to have opportunities to get almost the same level of care as the other population. And on the quality side, of health equity, most of these patients, their first language is not English. They also, being immigrants, I'm immigrant myself, coming from China, even though I had very little understanding of how the healthcare system works in America. I was afraid of going into doctors or emergency rooms because I don't know how the billing works. I don't know how much I'm going to be paid. I had a patient who is a fairly wealthy, immigrant from I think he was from Ireland, but he came to our clinic because he didn't know what to do. He went to the emergency room for a few hours and he got a bill of $1,500. Like, these are the things that are culture shock to almost everyone who didn't grow up in this country. So the health literacy, and this is, this health literacy, I mean this, in the way, just like the basic understanding of the healthcare system is extremely challenging topic for most even native American citizens. So I think lack of health literacy and not speaking English fluently hindered the quality of healthcare for these patients, even if they had made it to the clinic, in a lot of settings. I think to address that, I don't know. I don't have the perfect solution to ensure that, like, patients who doesn't speak English as their first language will be able to get the same quality of healthcare. But I think, just continuing advocating for these patients, ourselves trying to educate our colleagues, to have everyone to have a little bit of patience and understanding for patients, for these patients, can be a first step, so that these patients will be able to have a chance to get the same quality of healthcare, when they're getting cared for, in our system.
Yeah, thank you both so much for talking about both healthcare quality as well as the financial aspect of it that often people don't immediately think of. Kate, you mentioned the model, I believe reimbursement model. And I just wanted to know a little bit more about how that works and if you as medical students at the home clinic are able to get involved with advocating for reimbursement models for the home clinic.
Yeah, so reimbursement model really, I don't have the power to do that right now because it's more of at a policy level. So just put it in, basically it is whether doctors are going to get paid by the insurance company, or like from taking care of these patients. Reimbursement is the payment, like the doctors can get if they are not getting paid by certain reimbursement. Like, is the most common term is like the doctor doesn't see my insurance, right? Like they don't take my insurance, like because they don't get reimbursed from my insurance company. So that can happen to anyone, with or without insurance. So I think, like advocating in that sense will be participating in organization medicine. Like the American Medical Association is an example. Every single specialty has their own organizations that they will vote for. So physicians, medical students, and even yeah, I'm not sure, medical student and residents, they can participate, writing resolutions to advocate for Congress so that the our CMS, which is the organization that overseeing Medicaid and Medicare, if they start paying for things, usually the insurance company will follow suit, paying for the same services. So if in the long run, if we're able to advocate for a big scale healthcare system change, so that we either have like single payer model or some other sort, or the Medicaid Medicare will expand their coverage to take care of these undocumented immigrants. Eventually these patients will be able to have some sort of insurance and be seen in a normal doctor's office if they accept Medicaid, Medicare. So like I'm not sure if that explanation makes sense. So it's unfortunately, we can't really do much at a local level because it's more of like a big scale federal level change. But there are venues for students, medical students, residents, doctors to participate, joining organizations, going to their Congress of Delegates at all levels and writing resolutions, right? Like advocating for certain change in the reimbursement model, will hopefully in the long run expanding access for these undocumented immigrants.
Thank you so much for explaining. So kind of piggybacking off of that question, what else do you think can be done specifically in the campus-wide community in order for students to advocate for more equitable access to healthcare, specifically for immigrants?
I think that what Kate was saying about health education and health literacy is probably one of the most powerful tools we have in trying to achieve health equity. Take, for example, during the COVID-19 pandemic, when we started to have vaccines available, or even before then, when we started to understand how the virus was spread and how to protect yourself from the virus, one of the things that our clinic did was sort of like an information initiative to help our patient population understand how to protect themselves from the virus. So wearing masks, social distancing, avoiding gatherings, that sort of thing. And being a resource for patients who had questions, because for a lot of our patients, they were not able to stay home and shelter in place. They had to go out and go to work. A lot of them worked in the service industry or weren't able to afford to take time off of work, things like that. So we did a lot of work with trying to make sure our patients understood how to keep themselves safe. And then now with the vaccine available, a lot of the work that we have to do as a community is to educate members of the community with low health literacy on how the vaccine works, that it's safe, that everybody should get it. And like Kate was saying, a lot of the barrier to that is, one, access to the information. So are we able to reach community members who aren't, in our social circles, who we might not interact with on a day-to-day basis or on social media, but also patients who have a language barrier. So are we making sure that the information that we're putting out there is in multiple languages? Do our patients understand us when we talk about it? And then in terms of, like, for example, the undergraduate campus, we have students who actually do medical translation for us. We have Spanish medical translator interns who work at the clinic and are actively helping to improve health equity within their community by serving as translators as our clinic. And we're actually recruiting for that now. We have a program called C-STEP through the undergraduate campus, where students can get elective credit for translating at our clinic, or we also accept volunteers who are native Spanish speakers. And that's a really great way to get involved in community health, because not only are they able to translate at clinic and work directly with patients, but we also collaborate with them on a lot of our health education initiatives and translating educational materials for patients to take home with them or to put in community centers or areas where different people can access them.
Absolutely. Just to add in a few things, and I think what Rachel was saying is absolutely right. Like, health literacy, community outreach are the most simplest thing that we can do. Trying to get more of the community, of the undocumented immigrant community to trust in our clinic, because unfortunately there are a lot of hesitations, just like trust issues in general, for in these communities. How do they know that they can just come to our clinic and not get deported, right, and actually get help? So it's like there were a lot of being able to build relationship with these communities, and through I remember pre-pandemic we had health fairs, we do like blood pressure screening, and in these kind of in these community, in areas that these communities gather, those are very important things that we continue, and undergraduate students can try to volunteer and look for these opportunities, and along with the health literacy, I volunteer for this organization called Community Health Literacy Projects, which is a student-led organization translating health health informations. Some are COVID related, COVID vaccine education, vaccine regulations, stuff like that. So like if students have any are fluent, or bilingual, or multilingual, and are comfortable doing these kind of health related information like translation, definitely seek out these opportunities. And maybe one of these handouts will be able to end up in some immigrants who really, who can really help them, to understand what exactly these health policies are going on. Yeah, another thing is just really, I think, support for our SB Home Clinic. I think the steering committees, like Rachel and all of her, like all of her colleagues, they've worked really hard outside of time. I think I'm in awe all the time, just because this is really a truly student-run organization, and so many students put in a lot of hours into this clinic, which is it's just amazing to be able to get connected with an organization like this. So if anyone is willing to support SB Home in any way, volunteering or any other connections that can help our clinic to grow and function any better, that's also a great way to support this cause.
Thank you so much. I think just taking care of a language barrier can be such a simple step that can lead to really big improvements in health literacy and health healthcare equity. So I'm going to pass this on to Jolie for our next question.
Okay. So going into the next question, in your service at the home clinic, what are some unique cases that you have seen that really stood out to you or had a big impact on you?
I think that my first year, when I had initially started working with the steering committee, I was working with patient scheduling and contact. So I would get calls from patients, and then I would kind of triage them and figure out what to do with them. And one of the most striking things to me was how integrated our clinic was in our patients' lives and how much our patients really relied on us. So I had a patient, she was primarily Spanish speaking. She was newly immigrated. She came in with really bad abdominal pain and she was found to have a peptic ulcer. And we did a stool study to see if she had H. pylori, and the stool sample got lost. And we had to have her come into clinic again. And it was a whole ordeal because for a lot of our patients, coming to clinic is really difficult. You have to get access to transportation. You know, if patients work on the weekends or on Sundays, when we have our clinics, they have to get time off from work. A lot of our patients need to get childcare. So there are a lot of barriers to get to clinic. So it was really, really difficult for her. And I remember feeling such an enormous sense of responsibility, because if we weren't going to take care of her, nobody was going to. And this was something that was really impacting her lives. And I think that this patient in particular, this was the first time I felt like, you know, if we don't help this person, potentially nobody else is going to be able to. And that sense of personal responsibility was something that I had never really experienced prior coming to medical school. And it had a really huge impact on how I see my education and how I see, you know, the purpose of my career. So, you know, SB Home is such an incredible place because we learn how to take care of people, not just as medical problems, but, you know, holistically as a person.
Yeah, so for me, I think being able to well, some of the examples, like I mentioned earlier, there was an Irish immigrant. You know, he's so different from all the other patients I've seen in the clinic because he was well educated. He works. You know, he has a decent amount of income, but and yet, you know, he was still in need of our service because he had very little understanding of the U.S. health system. So mostly that visit was a health coordination visit. I was trying to explain to him, you know, like why he needs to go talk to social work to take care of the bill that he got from emergency medicine, and how is he going to ever be able to afford a elective surgery to fix his hernia, you know. So it's like that was a different, you know, a unique example of, like, you know, the patient is so different. Most patients I have, they actually have a more financial barrier, but this patient is more of like a health, you know, healthcare system navigation kind of visit. It just kind of speaks to how diverse our clinic is. I think SB Home actually has a very good reputation among, you know, most clinics within Stony Brook. You know, we are well known within like the emergency department. Sometimes they would refer patients to contact us for a follow-up visit after ED visit. And some, you know, we work very closely with the resident run, also free health clinic for OBGYN. It's called Access GYN. OBGYN resident, they run it. They have ultrasound on site. They do mammogram. They do pap smear. So like we refer to patients to each other too. So like we're kind of generating this little tiny little network, you know, like of healthcare resources for patients who doesn't have health insurance. And I think, you know, like another example of, you know, like just unique, I guess, like, you know, like other unique cases I've seen in our clinic is just seeing how, you know, very young, a young patient in his 30s but he came in with so many complaints, pain almost everywhere, in the neck, in the back. And sometimes you ask him about his back pain, he will start jumping around to his like neck pain, or and he just very heightened anxiety. It's kind of an example of what we mentioned earlier, like they kind of accumulate these complaints, and then they also have like anxiety about their complaints, but they worry about the cost. So like eventually when they make it to the clinic, they have a lot of concerns they really want to address. And I remember trying to my attendings, like, of all these 8 problems you just presented to me, how many do you want to address today? I was like, as many as possible. But my attending, Dr. Morelli, she said, it's probably not possible to address all 8 at the same time. Let's try to let's communicate. Let's try to address the most important 3, and then we'll see him back in a few months. So kind of explaining to this patient, like, we definitely hear all of your concerns, and I just want to prioritize certain problems versus like just rush into address all of them at the same time. And hopefully that he will be willing to build a relationship with us and come back for the continuity aspect of care. That's what that was a very important lesson for me to learn. How do I navigate cases like this as a medical professional. Like, sometimes you can't do everything in a single day. Like, it's you cannot build Rome in a day. So kind of like take it back size and try to build that rapport so the patient will be able to follow up with us. Was all very, very important.
Thank you so much both for your detailed answers and just learning about different cases.
All right. Before we move on to our next question, unfortunately, one of our medical students, Rachel, has to go, but we'll be making her email accessible for anyone who has questions about the clinic. And if anyone is interested in becoming an undergraduate medical translator, as they mentioned before, they can reach out to her about those applications.
Thank you. Thank you for coordinating this. It was lovely to speak with all of you about this. And thank you to Kate as well. I'll talk to you all later. Bye.
So Kate, I have a question for you. So you had mentioned before about like you realizing that there are some discrepancies in how you treat like children versus adults and how they're not able to access the same care. So I just wanted to elaborate more on that and ask you, what are some of the other discrepancies you've noticed in the different populations that you've had to serve at the home clinic?
Yeah, so I think like we're not able to treat children mostly because I think just the structure of ESPN, what we're allowed to take care of, and the access to a pediatrician. Because sometimes we have adult internal medicine primary care attendings at our clinic. So I'm not 100% sure, like whether those kids are taken care of. But like even I don't have to be in SP home to see the different populations. Like I see a lot of all these a lot of immigrants, or even just new immigrants, right? Like they or very poor low social economic status patients in our university clinics all the time, because as Stony Brook takes all of these like public insurances as well. So I think like something that's notable is just I think if patients they're originally from a different country, sometimes they would not only they have that language barrier, that kind of prevents them from presenting all of their concerns in a very clear way. That will actually lead to poor health outcomes. In the hospital, sometimes we see patients, if they're using Spanish, we have to get out a phone translator, and like our time spent with them would be like much briefer, because sometimes it's already taking a long time because we're talking to the Spanish interpreter. And then it is a horrible thing sometimes to say. It's horrible to see sometimes, that like someone in our housing, or sometimes unfortunately ourselves, because we're rushing, we're trying to get to different things, we cannot listen as much to patients whose first language is not English. And 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 sometimes even just like in the hospital or in the clinic, because of we were not able to find the medications or the therapies that the patient will be able to cover. So I think at the end of the day, it's still like their access to healthcare exists. The access issue exists, not just for undocumented, uninsured patients as well. A lot of the lower income populations, they have very limited access in our healthcare system, and that definitely like that builds, it just kind of like builds up multiple hurdles for them to achieve that, to achieve the good outcome, really, because they can probably can't, they every time they go to see doctors, it's additional dollars because their insurance is cheap, and they are not able to get the best, most updated treatments like insulin. For example, insulin is a big topic recently. A lot of patients on like on certain not very good private insurance, they're just not able to get it covered. So I think like it's, I think we're repeating the same themes a lot of times in this talk, but access, healthcare access, causes a lot of discrepancies in healthcare outcome.
Yeah, okay. Thank you so much for going into that in great detail. You've been so like thoughtful and eloquent with like all the answers you've given, and I'm sure everybody's learning a lot. The next question we had was actually we wanted to go to the audience questions now. So we wanted to ask you this. This person from the audience asked, do you think Stony Brook helps immigrant students with access to healthcare? How can they improve? Earlier on, Rachel had mentioned how the Stony Brook Home Clinic is different than other clinics that medical schools have. And so this is also an opportunity for you to elaborate on like what exactly like makes it different, and like how are they better or worse at like serving that population.
Yeah, so I think I will address the audience question first. So immigrant students. So I think I will assume is helping immigrant students, like visa holder students. Like I hold the F1 student visa. For me, we're all required to pay for some sort of insurance, in order to be enrolled. And that actually, from my experience, notice Stony Brook actually, for the insurance for international students, international students and scholars is actually pretty cheap. It's cheaper than the ones that they provide for domestic students. But I think beyond that, I personally didn't receive any resources to help me gain access. Like to like teach me about like, oh, this is a premium, this is a copay, what is a deductible. I kind of had to learn all of them myself after a very painful ED visit. Because I got a huge bill of $3,000 that I didn't know what to do with. And I was kind of forced to learn these vocabulary, and and then later on I was able to kind of help my other friend who also had a biking accident to fight a lot of the bills. So I think maybe it is. I can't think of a good solution to what's a school, a university can do to help immigrant students, besides just having someone available to them, like a social work or insurance expert, because in the student health service in general, so that they can go ask questions to figure out like, hey, like I didn't grow up in this country, I do not understand how this is going to work. So it's like making that kind of resource, if it is already existing, more well known to immigrant students, can really reduce our anxiety. Like when we first came to the country, not understanding how the healthcare system works. And addressing, with regard to your second question about how student run clinics are different across medical schools. I think like it's just the from what my limited, I have very limited understanding of like how other schools, how the other medical schools free clinic works. But I think from what I've heard from my friends who was in the steering committee, Stony Brook, we're like a fully running clinic, that goes like twice a month, and we have like we just have very comprehensive services. We have established relationship with Stony Brook, overall, with the financial assistance, and we a lot of the like other specialties, like like they know of our clinic as well. And a lot of this probably also owed to our owe it to like our clinical medical director, Dr. Jaden Phillips. He's a family physician with Stony Brook, and he does a lot of advocacy. And I think making our clinic known and establishing relationship with other specialists and and lab imaging kind of services was able to make our clinic, we were able to do more because of it. And I know that is not something that just taken for granted. For a lot of schools, they probably have trouble being able to refer, do any sort of referral or studying. And there are also things, and yeah, so I think there's just a level different. I think of it as like different stages of growth, for a student run clinic. And I think fortunately Stony Brook is a pretty mature model, that we're doing. Or our students, our steering committee, they're not joking around. What they're doing, they're doing actual like very intense work to keep our clinic running.
Yeah, it's so great to know that we are so prepared and thorough, and that we are, like able to give those for referrals to patients who need it. So unfortunately, that's all the time we have left for today. Kate, once again, thank you so much for being here. We really appreciated the input that you had for us today and like all the detailed answers that you gave us. I certainly learned a lot from this conversation.
Yeah, it's a pleasure to be here. Thank you so much for organizing.
All right, so we'll be signing off now, but if you guys want to see more programming from the Center for Civic Justice, feel free to follow us at Civic Justice SBU on Instagram. And also, if you're interested in seeing more about what SB Home does, please feel free to follow Stony Brook Home on Instagram as well. All right, thank you guys so much for your time.
Thank you everyone for joining.
Thank you for joining, everyone.